The title of the seminar today, In a Time of Transition, was one that we thought was very appropriate because we all know the difficulties that are being experienced throughout the Irish health system in all shapes and sizes. But with every grey cloud comes a silver lining. And as we have heard already this morning from Maria, there is the possibility of utilising these challenges to our own benefit. But what I want to do before I go forward is hopefully go back. 1910, just gone, the 100-year celebration. 1910 saw the real kickstart, the founding father of the Joint Commission. This isn't a history lesson, I promise you. Many of you will have heard this, but I think it's interesting. Ernest Codman was a surgeon, and Ernest Codman, with a group of colleagues, and Dr. Chasson can explain this in more detail later, got together and said, do you know what would be a good idea? Why don't we have some basic standards, some basic ideas? And why don't we surgeons and doctors come together and discuss how we're going on? Now, they weren't difficult. They had 5 key things that they wanted to try and achieve. Each hospital should have a medical staff. I think we do pretty well at that stage. The members of the medical staff should be chosen based on graduation from medical school. Thankfully, it doesn't say which one. And that they would be competent and of character. Again, I think we'd be all right on that one. There should be regular staff meetings to review the cases. This is with regards to case studies. Very simple concepts. Medical records should be written and filed. Because at that time, most medical records were in the heads of the physicians. So this was a big aspect. And each hospital should have a clinical laboratory and radiology section. 5 basic principles on providing good care. When they came together in New York in the Waldorf Astoria, only 89 of the 692 hospitals that were involved were able to meet those 5 basic standards. And the interest of open disclosure, because the results were so bad, they burnt them. Does that happen anymore? Who knows? But the concept was, just over 100 years ago, the very basic concepts that we think about in relation to quality didn't exist. And how far we have moved on since those concepts. So jumping in my time machine, I'm going to move on to 1995, 85 odd years later, and bring it more closer to home with regards to Ireland. And that, for me personally, was when I first got involved working in the health system in quality and patient safety. In 1995, which is not that long ago, it was the first time that any type of external certification happened. ISO 9000, down in Galway. There were 2 quality coordinators in the country and 2 risk managers. The professional bodies existed, such as Board Alternate and the College of Physicians, but the standards and the assessments that they undertook were more subjective and focused on varying aspects in relation to it. The concepts that we discuss today in seminars such as this with regards to clinical audit, accreditation, learning from patient safety incidents, etc., were generally nice ideas. But that was about it. They didn't go anywhere. It was something that we would see in the future. So when I got involved in healthcare at that stage, it was really an eye-opener. Coming from an industry which had regulation embedded in it over the years, to a system which we would have imagined was regulated and focused on quality and safety, but had a very weak structure in relation to it. So it was certainly an eye-opener. But then the good times came. Then we had money. Then we could do something. 2010, between 2000 and 2010, we had the good times. We had the boom. We were able, within the Irish health system, to actually put resources within the systems that we required. As a result of that, by the year 2010, we had over 48 organizations involved directly with regulating quality or safety in the healthcare system over that 10-year period. If you break it down to the independent colleges, we had over 83 organizations that were actually coming to hospitals and looking for information on the quality of care that it provided. What was also interesting, though, was of how it actually was developed. And this quote in 2010 from John Billings, who was then the director of the Healthcare Quality and Safety in HIQA, I thought was pretty focused. There was a lot of knee-jerk reaction with regards to regulation in the health system. A lot of them were reactive in relation to the issues. And that was one of the good things that we had about money in the system, was that when issues came up, whether it was Lees Cross or anywhere else, we were able to react to that. We were able to put regulation in. We were able to put more support structures in. But unfortunately, what happened was it was fragmented. And it is still the same system that we have today. An evaluation we carried out in 2006 and then again in 2010 asked people who work in the health system, who deal, like yourselves, who deal with these type of issues, was there overlap in this? A whopping 64%, and by 2010, 83% said yes. We're getting paralysis by analysis at this stage. There's a huge overlap with regards to it. But unfortunately, the other side of the coin, when we asked the next question, again in 2006 and later in 2010, were there gaps? 77% said, yeah, there is a big gap. What was the big gap? Big gap was an overall framework, that we had individual pockets of different standards, different regulatory requirements, but to put that into one type of a framework which allowed us to progress all of these was actually missing. What wasn't missing, however, were the personnel. And unfortunately, when these new regulations were brought in as a result of being reactive to issues, the most common trend was we will appoint a manager in relation to it. We will appoint an infection control coordinator. We will appoint an accreditation manager. We will appoint a health promotion coordinator. By 2010, a survey we carried out identified that when one large hospital, there were 20 named coordinator managers responsible for quality and patient safety. It had an effect, through the resources that had become available, had become an industry in its own right. What was really interesting, following on from Maria's presentation today, was when that question was asked about how do people get involved, it was embedded. Maria said that that's just part of what we do. Unfortunately, because of the resource availability and the appointment of many of these people, it was felt that the role for patient and safety, the role for quality improvement was over there. So with all the money we had for the 10 years, what were the overall outcomes? There's no question the expertise became more available. You sitting in front of me, you are the expertise, much more than 2 quality coordinators and 2 risk managers back in 1995. It very much put quality and patient safety on the agenda. Clinical audit is talked about, infection control is talked about, audit is talked about, patient safety, incidents, they're talked about, they're on the agenda, which didn't happen 10 years ago. The difficulty, however, being victims of our own financial success, was because we were able to appoint people whose role focused on this, that it reduced the integration within the day-to-day services, the exact type of integration that Maria was talking about in the primary care centres in Barcelona. That it became someone's job, that it became our job. And that ownership, that responsibility for providing safe care, but also for being knowledgeable about, I need to learn from other people's incidents. I need to understand what regulatory requirements are out there. I need to understand what the benefit is to me providing care in doing things within the quality framework. That was unfortunately where that ownership became limited in relation to it. In effect, as I said earlier, what we created was essentially a quality and safety industry. It was almost another department, another part of the Irish health system. And I don't miss the irony, by the way, of coming from that industry. I understand that. And it wasn't something by design, but it was something due to those resources that were put in that essentially became separate from the actual care provision, a bit like HR being separate from the actual direct front line. So where are we now? Well, I'm not telling you anything you don't know. I just was given the job of trying to put a few of these things on PowerPoint. We have this huge expertise, but unfortunately with very poor utilization of it. Recently, working with a hospital, we saw a very experienced risk manager there for a number of years, taken up in administration of incident reports, essentially data inputting. Why? Because there was no one else to do it, and that job had to be done. We still have not managed to embed the very basics within those who are in the front line. The basic understanding of that if you are a manager, a clinician responsible for a care area, you need to know what the process is. And you need to nail down that process. And you need to ensure that you have approved that. It is the most basic concept. One of the most boring jobs we have is talking to people about policies and procedures. There's nothing quicker to knock people off than talking about policies and procedures. But the concept to try and get people to understand that what we're actually asking you to do is to step back, explain what the process is going to be, nail it down, and communicate it to your colleagues in line with what is best practice needs to be brought in. We still have not embedded in our culture learnings from the incidents that occur. We deal with incidents. We predominantly deal with them to reduce the level of claims, but we still have in that culture, it's limited with regards to learning from them. This again was brought home to me quite recently, working in one of the large hospitals where no debriefs had ever happened. All of the incidents that they were aware of, not in one scenario had they come together to discuss what had actually occurred and what could we do next time around. So when we have this scenario, we have a situation where we have duplication of effort, where we have a case that the research that is going on independent of each other. I always love the one that came out with regards to the number of incontinence policies and procedures that were developed in 2008. Throughout Ireland, there was a study done by a researcher, and they estimated that 100 plus independent policies and procedures were developed on incontinence. It's not that difficult. But because of the fragmentation, we have this continual duplication of effort. We have this difficulty in transferring that learning from where we're going. And one of the difficulties why that occurs is also because we're lacking in that quality and safety framework, that regulatory coordination. Those 46 organizations still exist. They still want information. They still want to see that people are improving, but it is done within independent pockets. And it is now, as we move forward to the next level, that we see that the framework for regulation, through the likes of HICWA, through the likes of accreditation, is coming forward. So, second last stop on the time machine. Where are we today? Well, it may come as a shock. We don't have any money. We have less resources. We have increased regulation. And we still have the problems with regards to patient safety. So to take Apple, who seem to be doing quite well in the world, with their concept of think differently, because this challenge is now in front of you and in front of us all, to maximize these resources, we need to look at how we can change things from where we are currently developing those systems in healthcare to try and promote and develop quality and support it. Two very quick case studies in relation to it. One is all the way from South Australia. And the South Australian Pathology Department, just over 2 years ago, just 4 years ago now at this stage, was brought together. They had 18 separate laboratories in South Australia. Lovely part of the world, very nice, a lot warmer. And they all worked independently. They had over 2,000 staff. So in 2008, it was decided that SA Pathology would be formed, and it would bring together these 3 groups, but essentially 18 different organizations. Sounds familiar. So they had to bring these together, and one of the main catalysts was rising demand and limited resources, the same challenges that we have here. Then, when we started to look at the quality system, so that was the organizational, they had 3 separate quality management systems. And in fact, they had 18 quality management systems because they had their own independent quality managers. They had 12,000 individual processes within pathology. They had significant duplication, but there was significant difference. In fact, the processes very rarely were the same, but they had similarities in relation to them because of the same function. Some of them had certifications such as ISO or NATA, which is the INAB equivalent in Australia. And there were different corporate cultures, different people wanted different things. So as you can imagine, a little bit of difficulty with regards to that. However, the body did come together and they set about an implementation as part of the overall consolidation of the pathology department into developing a common quality management system. Essentially what they wanted was to standardize what was going on and to reduce the workload. So they couldn't just continually keep going with the audits. Yes, party political broadcasts, we did engage to assist them. But essentially our role was very simple. It was a room not dissimilar to this, with about little more than half facilitating discussion on how can the processes work better, how can we have standardization, and how can we make more with less. One of the key aspects that they did involve in that, which was beneficial, and it was the CEO, Ruth Salam, who put it forward, was said, you need help, so we're going to use an IT system to help streamline and maximize the quality system that you have. In effect, being a smart woman, what she was hoping to get them, and which occurred, was to use that as a catalyst, because a computer system only knows one way of doing things, and to try and streamline that. And in return, they were getting automation as a result of it. So QPulse was the IT system that they undertook. And it was a 6-month project that was involved. What has happened? Well, this is over 12 months ago now at this stage. They really changed the way they did things. Not let's write new policies and procedures that it's the same policy that everyone will have. They said if you're responsible for your lab, you need to nail down what your processes are. And this was one of the biggest changes that we saw. It was independent accountability. The quality management system was not the responsibility of the quality manager. It was the responsibility of whoever was carrying out that procedure, the line managers, the department heads. They were accountable. It was their role. They standardized the protocols. As a result, they had less errors because they could identify what was best practice and try and standardize that. Rather than blanket going through numbering and audits and data, they actually focused on what are the riskiest areas that we have here. Let's not continually just do blanket audits for the regulators' benefits. Let's actually focus on what are the risk areas. They reduced their quality documentation by 50%. Now remember, they had 12,000 different processes. And in the first 12 months alone, they saved $300,000. They had a return on investment of 100% in the first 12 months. And they expect to see that double over the next 12 months. And most importantly, they improved their clinical outcomes. The audit process in Australia called QAP, which does an external evaluation of the clinical outcomes, false positives, etc., identified a significant increase in their clinical activity and clinical outcomes. So that's in Australia, and that's going on, and we see that quite a bit with different areas. Meanwhile, back at the ranch here in Ireland, it's happening too. The challenges that are coming with the transformation of the health system, we see and we hear a lot about the new hospital networks. And one of the first hospital networks is the Galway Roscommon University Hospital Group. And this same concept is being applied currently. It's just started in Galway Roscommon University Hospital Group, which is a bit of a mouthful. And the hospital network, which has come together with Galway University Hospital, Portiuncula and Roscommon. And they had 3 independent quality and safety systems. Never the twain shall meet. 3 independent hospitals. The difficulties there are the difficulties that everyone has. Less resources, redundancy, moratorium. So all of those staff that we talked about, the quality managers and the coordinators and the risk managers, were going, if not gone. And then we had lack of administration. So all of this work that we talked about before was being packed up on people whose areas of expertise were not administration. It was on patient safety. It was on quality improvement. And yet they weren't being maximized. So this continual rising demand and resource pressures was the same, no more than in Australia. So I can't give you outcomes at the moment, but what I can tell you is that the goals and the way that it's been approached is different than what we've seen to date. And the approach is, let's see if we can do this completely differently. And why do we need so many people to manage the quality of the care when we have business managers, we have clinical directors, we have the clinical managers, nurse managers, etc. And that we need to look at seeing if we can put the processes back and integrate it and embed it into actual frontline care. So the approach is to try and integrate this quality and safety directly into the day-to-day activities, reflective of what Maria was saying in relation to Spain, and to remove that gap, that disjoint from those who feel that's someone else's responsibility. It's not me. Quality, safety, that's someone else. That's over there. What we have as a result is that the expertise that we have available, you, the individuals, can be maximized more. There is a huge amount of work that has gone on in developing the quality and safety within the healthcare today. What we now need to do is to try and move that to the next level and to free up the expertise that has been created by doing things slightly differently and by allowing the experts within the organization that have developed so much, that have moved on, to utilize it in measurement, to utilize it in communication, and to utilize it in learning. And with those aspects, we can provide for a future which is different. We tried where we had lots of resources, and it did have an impact. It did move the agenda. Now we don't have a lot of resources, but surely we're in a position, because of the expertise, because of the knowledge base and the learning, that we can move that along. We need to be in a position, rather than trying to manage the processes, that the processes become embedded within our own systems, and that we are the ones who can evaluate it and use that information to develop it. We want to integrate it. We want to make sure that the owners are responsible, that it is their area of care, it is not someone else, and that the concepts of the people who are involved in quality management and patient safety are there to support that, to help educate, to help communicate, and to maximize the resources. Necessity is who is the mother of invention? Very good, but I think Philip's had it a little bit better. I think we can make it better. There has been a huge amount achieved, but I think it is now, because of the challenges that are ahead of us, another opportunity, an opportunity to move it on, to transform the quality and patient safety movement that has been successful to date.